My name is Kim Suderman, and I work for the County Behavioral Health Directors Association. I am a retired behavioral health director from Yolo County, and I also was a children's director, children's deputy in Yolo, actually, as well as San Joaquin and Sutter Yuba County behavioral health, so those different counties. And I also was an adoption worker back in the day, right after graduate school in Tulare County. So I'm really pleased to be here, pleased to have all you here. And today we're going to talk about complex care youth who have pretty major needs that are not always getting met in the traditional senses, and we have some great opportunities that the state has offered, and so I'm really excited to have you hear all about it. Our first presenter is Locke Wynn, and he is from the County Welfare Directors Association, and I'll let him introduce himself the rest of the way.
Good afternoon, everybody. So today we're going to do a little bit of an introduction, talk about facility types, reframing the perspective, a little bit about the regional center perspectives, and then to summarize. As Kim mentioned, I'm Locke Wynn. I'm with the County Welfare Directors Association. And a quick shout out to the probation staff from San Mateo County when I was child welfare director there. I had a very close working relationship with Chief John Keene and his staff. So one thing to note, or several things to note about being in San Mateo County, at that time we had the only publicly run RCL 12, a 30-day shelter, which actually had 12 beds. In terms of that, we were also the only county at the time that had a publicly run foster family agency. So 2 county social workers, one focused on child protection, the other focused on being a foster family agency worker, and between them they had a combined caseload of no more than 10 children, which is pretty unusual in the county world. And at the time we were also the only child welfare program that was nationally accredited by COA, the Council on Accreditation. So in terms of facility types, there will be a number of acronyms here. STRTPs, you're probably very familiar with. CCF, community care facilities. These are the vendorized regional center group homes. Community crisis homes, also for regional center consumers. PUFs, psychiatric health facilities, the mental health rehabilitation centers, as well as community treatment facilities. So I'm going to talk about them in a little bit of a matrix. So some children, or basically those who are under 18, and also adults, and then compare them with placements and then psychiatric facilities as well. We're in our 5th year of continuum of care reform, and we've talked a lot about STRTP, so I'm going to focus on the other facility types that you may not be familiar with. In terms of that, some of them are covered by Title IV-E funding for care and supervision, and I'll talk about that as well. So let's talk first about the CCFs, community care facilities, which involve both children as well as non-minor dependents. So roughly speaking, and this is a little bit older data, around 3,500 foster youth who are at least 3 years old in California. 74% of them are with non-related resource families, another 24% are with care providers, and really only about 2% are actually in community care facilities. These are regional center vendorized group homes, which are officially called community care facilities. They are group homes that are licensed by CCL and vendorized by the regional center. So the higher the level of service, the greater the service need, and then the higher the rate that's associated with it. There are 4 service levels, 1, 2, 3, and 4, and then within the 4 you have 4A through I. You probably heard some of the regional centers, if you're involved in those conversations, talk about 4I homes. Each service level has essentially a defined rate that is broken down by whether or not you have 4 or more or 4 or less youth and whatnot, or beds. And vendorized homes in the regional center world actually do not have a mental health infrastructure. So it's one of the things that have to be built up from scratch when you are talking about with your regional center colleagues and whatnot. Now, a few years ago, DDS, the California Department of Developmental Services, recognized that there were going to be consumers that had higher needs than what a 4I home could accommodate. So in essence, they began to then customize the service needs based on what an individual consumer would need, and then negotiate a rate for that particular home. So in essence, some of these homes are called negotiated homes. They are still group homes that are licensed by CCL. Some of these homes are referred to as specialized residential facilities, and these SRFs are essentially for those who may be medically fragile or who have severe autism and whatnot. And then the highest level in terms of the negotiated home are essentially enhanced behavioral support homes that were created in 2014. And again, these homes were providing 24/7 services. Staffing had a little bit higher level of care, et cetera. So just to give you a sense, a 4I home is around $10,000 a month. The highest enhanced behavioral support home that I've heard of, that's actually outside of LA County, is around $155,000. That's a month, okay, in terms of that. So it's really leveraging and customizing the services to these particular youth. These homes are not specific to youth in foster care, although some of these homes do have them. And then they actually created the homes for youth back in 2019. So then they started to become available. Community crisis homes in terms of that. So these homes used to be locked facilities, and they were run by state-level staff at the Department of Developmental Services. So if a consumer was in these particular homes, they'd actually have state-level not only mental health clinicians, but also state-level behaviorists. They are now a new type of licensed facility that's actually licensed by CDSS, Community Care Licensing, called a community crisis home. And really, the only difference between these particular homes, as well as the old locked facilities, is that they're no longer locked. But everything else still applies. This includes having to have a referral from a regional center under what's called Welfare and Institutions Code 4418.7. That also includes that the individual has to be a danger to themselves or others. Some of you may have also heard the term STAR crisis homes, so that was, again, the old term for that. And starting in December 2019, they started to have beds for the youth throughout California. And again, these were not specific to foster youth or probation foster youth, but they were actually for all youth in California, but most of them currently happen to be foster youth. There are only about 10 to 15 beds statewide. So community treatment facilities, you'll notice that under this grid, it's really only available to those under 18 years of age. They are licensed by Community Care Licensing. They have to have a mental health program that is certified by the Department of Mental Health. By the California Department of Healthcare Services. In terms of this is the code section that's related to that. They are considered qualified residential treatment programs. So what that means is that youth still has to be determined by your interagency placement committee as needing that level of care, but they have to essentially go through a qualified individual and things of that nature. So there are approximately 68 beds with 2 facilities. Both happen to be in Los Angeles County. Vista Del Mar actually also has an SCHRTP on their grounds as well in terms of those. And again, these are for those who are under 18 years of age. They are considered locked facilities. Usually there are 2 general ways that a youth can be admitted. 1, that they volunteer to go into this particular facility, or 2, they have to be conserved.
And I'm just going to add a quick history thing. The reason there are only 2 CTFs and they're in LA is because those are the 2 that chose to stay in business. There were several throughout the state. Regionally, the only region that didn't have a CTF at all was in the central region. I'll stand because I just realized you can't see. So just, it wasn't because LA just gets to have everything. It's because those are the 2 that actually stayed in business. The others decided over the years to shut down. So And that's been that way for quite a while. So it's really a big deal that there are still 2.
All right. So mental health rehabilitation centers, and you'll see in this grid, usually for those who are adults, and they are psychiatric facilities or under that particular cell there. So they are formally the Institutes of Mental Disease. They are licensed by the Department of Healthcare Services. And this is an oversimplification, but I think of them as CTFs for adults, okay, in terms of that. They're not quite that, but if you want to think about them that way, that's a way that helps me sort of differentiate between what's available to individuals who are out there. So there are 32 in California with around 1,750 beds or so, and an individual has to have a medically necessary condition to be admitted. As such, you're going to have to work closely with your county behavioral health to get them admitted. 30 of the facilities are locked facilities, and 2 of them, by special agreement with the local regional centers, are unlocked, and they are focused on those who are regional center consumers. That's the one, Redwood Place in Alameda, Sanger Place in Fresno County. So under psychiatric facilities, you have the PUFs, the psychiatric health facilities and whatnot. In terms of this, there are 32 of them with over 600 beds. They are licensed by the Department of Healthcare Services. These are hospitals that specialize in psychiatric issues. So they are not hospitals that deal with general health issues and whatnot. And they require a referral form from a psychiatrist. And the individual there has to be some aspect about being a danger to themselves or that they are gravely disabled. So these PUFs, as they're known, are locked facilities. There are 4 of them that accept youth. You see them here: Telecare Willow Rock in Alameda, Central Star in Fresno, Starview that you're probably familiar with in Los Angeles County, and also ResPad Red Bluff in Tehama County. There are another 2 that will, on an individual basis, accept and waive that minimum 18 years of age criteria. What that basically means is that you have to contact them if they have a vacancy, and if they approve the waiver, then they may accept an individual who's under 18 years of age. So San Luis Obispo PUF, as well as ResPad in Shasta County, are the 2 that are adult facilities normally, but they will accept that waiver based on a request and availability. So state hospitals, again, in this particular grid, for those who are over 18 years of age and considered under a psychiatric facility, you have state hospitals that are essentially governed by the California Department of State Hospitals. This is the counterpart agency to CDSS as well as DHCS. These hospitals are for adults, and they are locked facilities. There are 5 of them: Atascadero in San Luis Obispo, Coalinga in Fresno, Metropolitan LA in LA County, Napa in Napa County, and Patton in San Bernardino County. And again, you would have to work closely with your behavioral health to consider admission into these particular hospitals. There was an appeals case back in 2021 that said basically that those who are found incompetent to stand trial must be transferred to a developmental center or a state hospital within 28 days of that placement order. What this essentially means is that for any other consumer, or any other client like a regional center consumer, they will be deprioritized until this cohort is addressed first.
I'm just going to add again that the state hospitals, there are not enough beds for all the needs. And so each county that is using a state hospital bed is probably not going to get another person in unless they remove the person they have placed. So it's important to know, but the decrease, and there were state hospital beds for minors, and that was eliminated as well. So just over time, again, knowing that congregate care or in-home care, family care is much better for people, but we do know there are some severely mentally ill and emotionally disturbed kids that are in need, and we have a shortage.
Absolutely. So you can see that there are a lot of facilities and there's a lot of considerations in terms of that. If there are any issues, feel free to reach out to your colleagues at CPOC, Stephanie Anderson. I'm the one who assists the child welfare groups through the TA calls and technical assistance, and we can certainly walk you through some of these as well when they come up. But one of the things that I wanted to focus on for the next few minutes is reframing the perspective. And what you'll want to do is meet internally with your probation team, with your counterparts at DMH or behavioral health, with even substance use program. Sometimes it's in behavioral health. The one in LA is actually through the Department of Public Health in terms of that, as well as your educational counterparts. So you'll want to determine what services and supports that a youth might need in terms of that. And then you'll want to determine that whether or not at baseline they need to be hospitalized or that they need residential care. And it's not one of those things where if there's no space available in residential care, then we'll put them in a hospital and vice versa. You actually have to start ahead of time trying to figure out, does this youth right now need to be in a hospital versus in residential care? The youth, if there are mental health issues, the youth will need a client treatment plan. And counties should work very closely with their behavioral counterparts, right? And if you're familiar with the client treatment plan, it basically has to define what are the mental health issues or impairments, what essentially are the goals. The goals have to be specific, observable, measurable, and then each of the goals has to have at least one intervention, right? The intervention has to have a clinician who will focus on that intervention and how long and how often that intervention is going to be. So it's actually very detailed. It's not a generic client treatment plan and whatnot. If the youth has substance use disorder aspects, they'll still need that client treatment plan. Again, this is actually working closely with your substance use disorder program colleagues in behavioral health. In LA, it happens to be in public health. But many times, the staff in the substance use side are actually not the same staff in the mental health side. So it's something that you'll have to be aware of in terms of that. One other thing, just a quick note, you may have heard of presumptive transfer, where you can presumptively transfer mental health to another county if they're placed in another county. Substance use issues cannot be presumptively transferred. So your county substance use program will be responsible for Medi-Cal SUD services anywhere that the youth goes in California. Okay? They may work with a local county provider or a local behavioral health to identify who a provider might be, but your local county behavioral health substance use disorder program will be responsible for doing the contracts, leveraging it, following up on any treatment plans, et cetera. Physical health issues. This is actually covered in Welfare and Institutions Code 17710, 731, and 732. So basically, if your youth has any type of physical health needs that goes beyond the norm, and this could be something as, quote, simple as type 1 diabetic who needs an insulin shot to something that is much more severe, you actually have to have an individualized health care plan. What that essentially means is that usually a child's primary care physician will lead a team, an individualized health care plan team, and that team will include you as the probation officer. It should also include a county public health nurse or another physical health clinician whose responsibility it is to follow up with any health issues that an individual may have. So once a individualized healthcare plan is in place, the case-carrying social worker and probation officer has to reconvene the team every time that the youth moves. So if the youth ends up going to another SRTP, from a physical health side, that team has to be called together by the case-carrying probation officer, and then your individualized healthcare plan team has to set the medical regimen. Okay, sometimes you'll hear a STRTP say, we can't take this youth because they'll require a nurse. This individualized healthcare team is the one that is actually responsible for telling that STRTP that's actually not in the medical regimen. This youth does not need a nurse at this time. All right. So one of the things that we recommend whenever you're considering a new STRTP, a new facility, a new CTF, an MHRC, et cetera, is that you get together, you, the probation team, your behavioral health counterparts, your educational partners, et cetera, to determine what services might you need and then where those services might come from. So one big aspect that you sometimes hear, an STRTP, a CTF, et cetera, will say, hey, we're going to need one-on-one services, and we can't provide one-on-one services for the next 30 days, 24/7, et cetera. This is when you begin to break down what do they actually mean by one-on-one, because one-on-one to them might just mean care and supervision, but to a youth with complex care, it might mean a number of things. So let's say you break down a day. What would a school day look like for your probation youth? So during, from say 8 a.m. to 4 p.m., one-on-one might be through their individual education plan. Right? Anything that the behavioral intervention plan within the IEP says, hey, they need on one-on-one, that'll be leveraged then. If they come back from the SRTP, from the school to the SRTP to the CTF, et cetera, they might need one-on-one through applied behavioral analysis. So usually, if it's a regional center youth, you can get a regional center to submit the referral. If it's not, you can get your primary care physician to submit that referral for ABA services. So ABA is essentially usually a master's level called a behaviorist, a board certified behavioral analyst. They'll actually put BCBA behind their names, and they'll come in and provide one-on-one behavioral health therapy. They'll do an assessment. They'll say, this is what they need. And it could be 20, 30, 40 hours a week. But in this case, you're saying it's needed between 4 and 8 p.m. Maybe because of their mental health issue is really manifesting at night between 8 p.m. and midnight, you're going to want one-on-one through therapeutic behavioral services from a master's level mental health clinician. Okay? And then, well, care and supervision will still want that one-on-one, but now it's only from midnight to 8 a.m. So what started as 24/7 care and super one-on-one is now that you're coming back and saying, hey, maybe we don't need you don't need the 24/7 care and supervision. Here's what we can leverage. And if we place this youth in your county, we've already submitted a referral for ABA services for 20 hours from Monday to Friday. We've also submitted therapeutic behavioral services and so on and so forth. Sometimes, if you feel that the transition into another facility is so traumatic, your team, your probation team, behavioral health, et cetera, may say that when your probation youth essentially is admitted into that facility, they may need 24/7 therapeutic behavioral services for the next few days because it is important to transition because they're very traumatized, et cetera. So you might actually work with some counties to offer that. That would mean that a clinician comes in at the moment that the probation youth walks through that door of that facility, there'll be a TBS clinician right then and there. It's really not about the behavior. And how many of you have heard this? Fire setter. We're not going to accept a fire setter in our facility or some other aspect, right, in terms of that. So there's fire setting, there's being assaultive, there is enuresis, there are AWOLs, there are all of these things that seem to be around behaviors, and you'll hear a provider saying, no, we will not accept them. What you'll want to look at is to really work closely with your behavioral health counterparts to understand clinically where the behaviors are coming from. Because a youth with this traumatic profile has some underlying mental health issues in which it is manifesting through some behaviors. So fire setting, for example, may be due to a child who has sexual abuse history. Okay? So if they come at you and say, we're not going to accept a fire setter, what you'll want to ask them is, does that mean you don't have a clinician who can deal with child sexual abuse? Okay? You're trying to help them, work with them to secure any of these entitled Medi-Cal specialty mental health services. It's not about telling you what behaviors they can't deal with. It's about you both understanding what is a service gap that you might be able to work on them with in terms of that. Enuresis, another one that's common.
We have
I'm sorry.
just a few minutes left before we can.
Thank you.
Yeah.
Enuresis, really quickly, there's a lot of wars going on. It's actually one of the first ones studied in refugee children in terms of picking up the toxic level response in terms of that.
You have more time. I was thinking we started on there. Never mind. You have more time. You're good, Locke. Sorry. I'm a terrible moderator.
She's just keeping me honest in terms of that. So it's one of the first things that they will look for in refugee children because of that fact. When we hear about it in our world, this 12-year-old, 15-year-old has enuresis, they are looking at it from, oh, they can't control their bedwetting and then we're going to have to clean them up. Versus if you're picking up enuresis before they come into the facility, and if this is starting to increase, it may be reflective of ongoing trauma that's being built up with them. Okay? And again, it's really how are you able to look at these particular behaviors and then understand from the probation perspective, understand how this Medi-Cal provider that you're going to, STRP, CTF, how it is that they're not able to address the underlying issues. And the only way to really do this is for you to work very closely with your behavioral health counterparts in your county. Same thing with enuresis here. All right, I'm going to talk a little bit about hospital discharge planning because it is one of those things that has come up. You'll hear that a youth has been 5150 and a hospital will say to you, the emergency psychiatric issue is no longer medically necessary. Come pick your youth up. Okay? How many of you have heard this before? Right? We've actually had child welfare directors and staff being threatened with arrest from the hospital for not coming and picking up their child. So one of the things that you'll want to keep handy is Health and Safety Code 1262.5. It is actually a codification of federal law under hospital discharge planning. And what it essentially says is that hospitals have to have and must work on hospital discharge planning for every one of their patients. They are only obligated to tell you when an individual is discharged, but upon your request, they have to do additional things, including what's called hospital discharge planning evaluation, if they think that an individual upon discharge will have a significant adverse health effect. Okay? And what this essentially means is that, and I can almost pretty much guarantee you, a youth coming out of the hospital is likely going to have a significant adverse health issue if they're not careful about this. And this could be a physical health or a mental health issue. What hospital discharge planning evaluation encompasses is essentially that they have to figure out, hey, what is this probation youth going to have health-wise? And what services, health services, does that probation youth need upon discharge? Are there any PAC facilities, post-acute care facilities, that would be able to take in this youth who have those services that we've identified? Now, they may say to you, or you might say to them, hey, we're here to address the youth's safety needs, but when you, probation, talk about the youth's safety needs, you're talking about care and supervision. Okay? When they talk about safety needs, it's at the time of discharge, does the youth still have a significant adverse health issue that could cause them harm, that could end up hurting them, or that could end up killing them? Not to be overly dramatic, but that's the point, right? So your probation office is not an appropriate PAC facility. An STRTP is actually not even an appropriate post-acute care facility if they don't have the clinicians right then and there upon discharge to be able to address the youth's needs. Now, this is not to say that you're trying to get into it with them and say, hey, keep them until you do this, et cetera. You're just trying to confirm from your end, you're still responsible for that long-term care and supervision as the placing agency in probation. But what you're concerned with is that when your probation youth leaves that hospital, are there any health issues which could compromise their health? And that's where the balance is. And you have to differentiate this between they no longer have a psychiatric emergency. That's fine, right? How many of you have ever had relatives who've left even the ER? What do they give you? They give you this little thing that says, hey, if you see these symptoms, make sure that you call the nurse. Here's the medication, and so on and so forth. Okay? So it's not as though they're not doing this behind the scenes. It's that you're trying to notify them as soon as your probation youth gets into the hospital. We, probation, are the authorized representative for this youth. We would like to work with you on hospital discharge planning so that we can make sure that when the youth leaves that hospital, they'll be safe health-wise. All right.
Let me just add, and by the way, Luck and I did agree that I would jump in during the mental health components of this, so just to add, when a youth or child is being released from a psychiatric facility and they're supposed to be going to a placement as opposed to back home to a foster home, the office is not a placement. And so one of the things that's really important is the hospitals are required to help assist in looking for placement as well. And so they should be helping to do that. Now, I don't know how many times I've polled a hospital to ask them how many and who they called, but they are, per their contract with the Department of Healthcare Services, are required to do that as well. So one of the things that you do want to do is ask that if you have a problem, they are not releasing the child in what Locke has described as a healthy way, not keeping everything in mind, there is a complaint process. And I forgot to give this. So Stephanie, I will send to you the letter that I have sent out to our CBHDA members that gives you the process to file a formal complaint. One of the things you'll find is that, unfortunately, that if you don't complain and we just give case scenarios during a meeting, usually that doesn't have the outcome that you're looking for, because the hospital association will say, well, we didn't get any complaints. The hospital, such and such, there's nothing on record. So we are actually encouraging folks, if you are finding that the discharge planning isn't done well, that something isn't done, we've had kids not get admitted on a 5150 when they should have. That's a formal complaint. There are two places you have to complain to. DHCS does, so the hospital department, DHS, Department of Hospital Services.
Yeah.
Is it services? Anyway, they actually approve the hospital, and then to make them their psychiatric unit meet criteria for 5150, that is done by DHCS. So it's two places. I will send that to you, Stephanie, and then you can send it out to those attended the conference.
Oftentimes from a facility, you'll get a critical incident report, right? Your probation youth has AWOL, your probation youth has attacked someone, and so on and so forth. If someone intentionally runs a red light and causes a really serious car accident, would you recommend that the driver goes to the ER, especially if you see some injuries, right? Sort of, yeah, why or why not? Think about that for a little bit. And then what if you were the police officer on scene of the previous accident and knew that the driver had recently come out of the hospital from that, and then suddenly you're here at this accident and it looks like they have more serious injuries? You're probably going to recommend, you ought to be going to the hospital. because I'm not the medical expert here in terms of that. It'll be the hospital that has to determine that you, whether or not you have internal injuries. Now, I'll deal with the fact that you intentionally ran that red light later. But first and foremost, let's deal with your physical health issues. So a youth on probation in foster care with complex needs who has this trauma profile and some continued trauma that's happening, and then each of the youth, you get a report from them. They AWOL, they attacked someone, and so on and so forth. You'll want to, or what I'm suggesting, is that you'll want to probably have a clinician examine them to see whether or not they've had further traumatic injury. I know, first thing, it's already the report, et cetera, and whatnot. They were the ones who started the fight. They were the ones who assaulted someone, and so on and so forth. But this still doesn't mean that they could have been further hurt mental health-wise. Okay, so it's something that we recommend in terms of you looking in on them. Just like that police officer would recommend that person with a physical injury go to the hospital because they're not a medical doctor, it's something that you might suggest, hey, we need to work with our behavioral health counterparts to see if this probation youth has had further traumatic injury. Because the implication is if they have had further traumatic injury, that could mean that they may need what? An adjustment to the client treatment plan. They might even need their medications adjusted. Sometimes you'll hear their medication hasn't worked so far, now they've had further traumatic injury in terms of that. So last sort of section here, regional center, if for those of you, and the reason I know that probation may not have a lot of regional center youth, but when they do come up, it's going to just zap a lot of your resources. So know that every regional center has a person responsible for knowing who the foster youth are, probation or child welfare, in their regional center catchment area. They're known as the 2083 Systems of Care Coordinator. Okay. And they also have, just like your probation youth has a client plan, they have to have an individual program plan. And then we recommend that you have a combined meeting of your CFT and of your IPP. This essentially means that all the formal parties at your CFT, including the probation, et cetera, and all the formal parties that would be at the IPP would be at the same meeting so that they're addressing the same things. Okay? And a lot of you are probably familiar with the DSM-5. There's actually the DMID-2. It's the 700-page companion guide to the DSM-5. So it basically says, here's an individual with PTSD, but what would PTSD look like in an individual who has intellectual and developmental delays? And what would PTSD look like in an IDD youth who's under 5 years of age, right? A normal person with PTSD might express themselves when they have thoughts, invading their minds, et cetera, from that PTSD. A very severely, an individual, a youth with very severe IDD, when they have thoughts invading their mind, might go to the nearest wall and bang their heads, trying to get their thoughts out because they can't verbally express it. All right. So a big thank you to all of you. I've covered placements in psychiatric facilities, covered complex care. In terms of that, my contact information, should you need it.
Locke, why don't you stay up here and we want to see if people had questions. Stephanie has a few. We are a small enough room. I'm thinking if people need to shout out afterwards, we can do that as well. Thank you. Okay, so the first one I want to run through is, so STRTPs are not required to have the clinicians on staff for when the youth is discharged from the 5150 hold. Okay, so I'll read this whole thing and then I may have to ask some clarifying questions. So they can use this as an excuse to not take the youth back after a 5150 hospitalization. The PowerPoint says juvenile hall is not an appropriate PAC facility, so where does the youth go? So You know, the STRDP is required, and I know we have folks here from licensing, from CCL, but the STRDPs are required to have clinical staff available 24/7, right? So 24/7, there aren't 28 hours in a day, so there's 24/7, so somebody should be available. That phone is fine, phone meets the minimum requirements, but when and a hospital, I want to hear if a hospital releases a kid in the middle of the night. But a hospital should not be doing that. They should be releasing them during approximate traditional business hours unless there's a prearranged because of transportation or whatever. So first of all, they absolutely should have clinical staff available. That's not usually the reason, in my experience, and I'll check with Locke to see if that's the reason that, have you heard of that being the reason an SCRTP did not pick up a youth from the hospital because they didn't have a clinical staff available? Yeah, usually they just don't.
Usually they've already discharged the youth upon.
So there's no
upon that.
bed.
Yeah.
Yeah.
So there's a couple of things here, and we actually work with one county, is that, again, as soon as that child enters the hospital, you'll want to not only verbally and in writing notify the hospital about that, but bring your STRTP counterparts with you to a meeting with the hospital to begin to do discharge planning, right? In terms of it, right off the bat. Basically say, okay, STRTP, this is what happens if the hospital is going to release sometime in the future. We know that's going to happen. So what are you going to do? We'd like you to keep the bed open. We'd like you to do X, Y, and Z. Hospital, this is what we would like you to do as well, okay, in terms of that.
As a follow-up to that same question, are the STRTPs required to do a meeting, or can they just say, no, we've made up our mind, we're not taking it back, there's no meeting necessary?
They are required to work with you until they do a formal discharge, right? So unless there is some aspect about them invoking the emergency discharge because of safety, until they formally notify you, they are already working with you. And also, all the elements around ACL 17-122 about the emergency CFT is that, you should be working with them right off the bat, right? So ACL 21-116 basically says that the probation officer, as soon as your probation youth goes into an STRTP, should be documenting in their case plan efforts to coordinate discharge planning with the STRTP. So we will want to include what happens if they're getting to this point. So it's not like everything else that we say, right? We don't ever want to have a surprise. So you should have constant meetings with these individuals.
And Friday at 5:30 is irritating because that's just unacceptable, really, from the hospital or from the agency facility not saying, oh no, we're not picking them up. So there are processes for filing a formal complaint with CCL regarding the STRTP. But as Locke said, if they haven't done the discharge, then they're not discharged. And if the hospital's ready for release, then they get to pick the youth up. Now that maybe you can assist with transport, but they shouldn't be doing that. And again, there's a complaint process. Here's a question: Is there a risk? Needs evidence-based practice tool to determine services and supports, and if at baseline their needs require hospitalization or residential facility. So is somebody asking if there's an evidence-based practice and EBP to determine that, one that behavioral health and child welfare uses the CANs, but it doesn't specifically determine hospitalization or residential facility. So I want to make sure we understand the question if somebody's willing to say a little bit more. Okay. Oh, all right.
Well, I'll say it this way. Think about a hospital in terms of physical health, right? Nobody wants to live in a hospital for whatever reason it is. Hospitals are there to address sort of emergent acute situations, right? So when you're looking at a particular individual who is in crisis and you're trying to determine, do they need a hospital, like a psychiatric health facility, versus a residential treatment, you're essentially asking them, are their needs so acute that they shouldn't be in a residential facility, that they need to be hospitalized in order for the hospital to address their health needs? And it could be a combination of physical health, mental health, and other aspects. Or can they go right into a residential care facility? So it is working closely with your CFT and everybody else to basically determine what's the difference at this stage.
So I'm holding 3 kind of mental health questions, but I'll still, Locke and I can still tag team this. Are these the only reasons? Are there any reasons why a psych hospital wouldn't take a youth something that is listed as a 602 versus 300? There should be no reason. It should have nothing to do with their legal status. Recently had a youth refuse services at a psych hospital due to youth being a 602. There are times, I will say, when youth are considered very dangerous, and I have worked in counties that have their own PUFs, that they will ask somebody from juvenile hall or from probation to be there 24/7, which isn't a very exciting endeavor, but it is sometimes the way to ensure that the youth is safe or that staff are safe. But legally, it's not about, it shouldn't be that way.
Yeah, and when you also hear that a youth is not ready to go somewhere, then what I say is work very closely with your behavioral health counterparts to clinically prepare them. You know, the admissions process, one of the most traumatic experiences that a youth can face. So if it's preparing them for the interview, preparing them after they have their interview, preparing them even for a rejection from an STRTP or CTF could be very, very important, because some of these youth have faced numerous rejections already. So it's not so much about what a provider says. You know, that youth is not prepared to have that conversation. That youth is not a rational adult making an everyday decision. That youth is a very traumatized youth who may be in the middle of a traumatic episode where they aren't prepared to have that conversation.
PUFs that accept minors, what is the criteria for placement? Is compatibility considered?
It's basically, again, based on the referral from the psychiatrist. So it's not so much that they are saying what is compatible with the hospital. It's a hospital, right? So they are trying to determine, based on the psychiatrist's referral, if this youth needs to be hospitalized in a hospital setting in order to take care of their needs. They just happen to focus on psychiatric issues.
Let me just also clarify, PUFs, MHRCs, none of those are placements. They're really a psychiatric service where you have to meet medical necessity, just like you have to meet medical necessity for outpatient services. So there's no, well, they'll be there for 6 months and then we'll look for a different placement. That's not how they work. At any point when they no longer meet medical necessity, they do have to leave, but they still do need, if they need that service and they meet medical necessity, then that's the discussion you want to have in relation to that. Once in a while I hear, well, right now on the unit, we only have 11, 12-year-olds. We only have 12, 13-year-olds. And to put a 17, almost 18-year-old youth that is a budding pedophile isn't a great thing. That makes sense to me from a clinical standpoint, but boy, that's rare that I hear that kind of reason. Okay. If youth is presumptively transferred and receiving mental health treatment in another county, but now also needs substance use disorder, SUD services, does the Medi-Cal need to be transferred to that county? So I'll take this one just, so it isn't transferred because presumptive transfer That bill was specifically for specialty mental health services. The SUD, drug medical services, stay with the jurisdiction behavioral health department, but the host county and the jurisdiction county can work together to try to figure out how to provide services. And honestly, I've heard many, many behavioral health departments that their SUD side of the house will provide the services. So there's a lot of arrangements that can be made. So this is one where you really want to work with your jurisdiction behavioral health agency, who should know by then, before you're placing, that there's a drug medical need, and so that they can help you work together in figuring out what that kid is going to get depending on where they go. Are the studies that support fire setting indicating history of child sexual abuse? So, Locke's probably heard me say this many times. There are some patterns that we see that often when there is, particularly I saw it in adults when I worked with adults, that sometimes that rage and those sexual issues, I saw adults that were doing things. I had a client that literally was just riding out on horse setting fires, and then she'd actually watch the fire department come and put them out, and then she'd go to jail, and then she'd be released, and she'd do it again. But it also is can be that, that example of the burning fire within you. And so some kids, not all, it's not cause-effect, but there is some correlation with sexual issues. So is it a sexual trauma? Maybe, but it may be sexual issues, trying to figure out what I think and feel and believe sexually. But there's that burning thing going on you. Again, not cause-effect. So that was way more clinical than you may want. But that can be there. It also is just flat-out rage. I mean, there's a lot of rage. I mean, when you think about people say raging fire, so you can see, kind of think, if you think of some of those analogies, those pieces can be in there. Again, not cause-effect. Hopefully that helps. In regards to post-acute care facilities on hospital assisting with placement, how does that affect funding, sorry. How does that affect funding with placement or QI process?
So
within SCRTP?
So hospital discharge, again, is not related to long-term placement. It is how the hospital is dealing with a potential significant health issue, adverse health issue for a client. We actually had one situation where when we asked the question, hey, if this was not a child welfare use, what program would you suggest? They actually said something called a partial hospital program, which is, again, not a placement, but an actual literally a partial hospital program. So when we're talking about post-acute care facilities, it is just that, think of it like a clinic or another type of hospital maybe that's in the community that addresses the temporary needs of an individual to address their health issues. It is not to address their foster care placement issues.
So Paul online, which we will see shortly, is asking, can Locke clarify the...
Oh, DMID?
Oh, the companion guide to the DSM-5.
So, yeah, tell a non-clinician to talk about DSM-5. So you all know what the DSM-5 is, right? It's a whole set of experts who have come together. They created 900 pages of everything from, it has, for every sort of clinical issue, they have symptomatology, etiology, and so on and so forth.
And it's not only mental health,
Right.
because there's all the DDI stuff in there too, so.
Yeah. So what ended up happening was that the folks who had expertise on the intellectual and developmental delayed side said that there were a number of things which made looking at individuals with mental health issues very differently if they have IDD. So for example, if you looked at a group of children who had depression, they tend to have similar symptomatology, etiology, et cetera. If you look at two individuals, or if you had looked at, let's say, 100 individuals who had IDD, who had depression, each one of them may manifest differently in terms of that. So what these folks did with the DMID-2, the Diagnostic Manual Intellectual Disabilities version 2, was to begin to try to capture some of the things that would be consistent, but to recognize that these issues with very severe mental health issues also had intellectual and developmental delays.
And symptoms and behaviors can look the same, but come from a very different place, depending on what else is going on for you. So if you have DDI, you could do the same behavior as someone who doesn't, and they have two different meanings. So we can't just group everything all together, and that's one of the things the companion manual does.
And with a lot of the clients under DSM-5, including youth, one of the things that clinicians can often do is ask them to talk about what it is, right? But when you're talking about an IDD individual, many times they're nonverbal. So how do you then capture some of the symptoms from a nonverbal individual in the same way?
I just realized I said DDI instead of IDD. Okay. We have a probation kid. She was a regional center client. They have found a placement and presented their petition at court, one placing the minor in an RC home, a regional center home. She was never placed via probation. Who is the lead agency? Great question. Who pays the bill, probation or regional center?
So if you have a probation youth who is in probation on foster care, there's one last thing out of what was called TANF foster care, if you're familiar with temporary aid for needy families, foster care, that was left over and incorporated into Lanterman. The LPS, I forget what the...
Lanterman-Petrus Short Act. Those are three different people.
What it essentially said was that any youth who was in dependency or in foster care on either side, and essentially they were TANF foster care, it would be child welfare and probation that was responsible for care and supervision funding. Now the trick is, anything that is put into the IPP, the regional center is responsible for. So that's why it's so important to have a formal combined meeting with them and then to make sure that that IPP is detailed. Any services, any other resources that was listed in the IPP, the regional center is responsible for funding, securing that, et cetera. But in terms of placement, if they are in foster care, then probation and child welfare would be responsible for the foster care funding piece of it.
Yeah, so the jurisdiction makes a big difference on that piece. Yeah.
Can I clarify that this youth was solely a ward and has never been a dependent child of 300? She's a 602.
She's 602.
And she's a ward, but she's never been in foster care.
Yeah. So
Parents still involved? But she's a CPRC client.
Are parents still involved?
Grandma's a guardian, but she can't be there because the victim's there.
In that particular case, if I understood your question, then it would actually be regional center,
Regional center should put that.
because it's not a TANF foster care case at this point.
And are they the
Did-
lead?
did the-
Obviously, we're going to be support.
did the court order placement?
Not placement like we normally do through probation. I wasn't there Friday, but whatever that form is, I couldn't think of the number and put in that question.
Uh-huh.
But it's that form that CVRC does to get their placement order.
Oh, okay, yeah. So it does make a difference if the court does a placement order. That really, because then it immediately makes the court jurisdiction or 300. If they don't and do that, I think it should be regional center, but it has to be written in the IPP, as Lux said. Special ed has to be written in the IEP, and whatever's written in the IEP, they have to provide the service. So really important to differentiate, including like the examples Locke was giving about the one-on-one and those kinds of things. That's really important. Two last things. Oh, sure. Yeah, no,
I'm going to speak. So one thing that's really important is that sitting down with your partners and having that discussion all together and having that CFT IPP meeting together can create that path forward. Because understanding your specific situation, it's really hard for us up here to say exactly what to do. But together you should be able to move it forward. In the event that you run into an incident, by all means, reach out to the intensive TA unit at CDSS, and we'll be happy to have a 2083 call, and it would include myself and Christine Bagley from DDS, and we can work to problem solve to figure this out exactly.
And that's not the case here. We are all putting our heads together and coming up with it. I just wanted to present the question.
Sure.
We did reach out.
That's great. Thank you. Okay, so San Luis Obispo just wants to make sure, San Luis Obispo PUF no longer takes any youth, regardless of waiver. So that's just an FYI. And then last question, if youth, did I read this already? If youth is presumptively transferred, receiving mental health treatment in another county, but also needs SUD services, I did that. Okay. Thank you. Let's give Locke a hand. Dr. Locke Wynn. Thank you, Locke. Okay. So we are now going to shift to our other panel. If I can get out of here. And hopefully, Paul, you're going to come up on screen here in a second.
I don't think I'm gonna be on.
Oh, we only have audio. Bummer. Okay.
So they say I had a face made for radio. So.
Okay, so let me just,
I wish I could be there.
I know, huh? Let's see. I know there's a way. Oh, here. Okay, so I want to quickly introduce everybody, and I'm going to use this just to make sure I don't forget anyone. Okay, so first we have Diana Wagner from CDSS, and you can give a more little background if you'd like to, who is a previous child welfare director, and she's going to tell us a little bit about what's happening at the state level with different things in relation to complex care and what's the other one? Complex care funding. Yeah, all the three different pots of money. And then we're going to have Paul Vince. Did I say your name right?
Vinette.
Okay, good. So Paul from LA County Probation is going to speak. And then Rachel Leitenberg is going to speak from Riverside. So I'm going to let each of you go ahead, and you have the clicker. I'm going to stay up here, and we'll let you guys kick it off. And Diana, I'll let you or whoever's doing the clicking. It should be, just keep talking into it, it should.
Hello?
Yeah.
Okay. Hi, my name is Diana Wagner, and I am with the California Department of Social Services, and also a member of the 2083 System of Care team. So I get the opportunity to work with CDE, DHCS, and also DDS in order to really create a system of care approach to our children, because we recognize that without coming together and working together, we are going to continue to work in silos and not make a difference for our children and families.
You can just use there's two mics.
Okay,
Just
I
use
know
that
our,
one.
he's
You're
trying to
just-
switch back and forth, okay.
Yeah, then you don't have
Very
to
good,
switch.
thank you. My name is Rachel Leitenberg, I am a probation division director for Riverside County Probation. Our division takes care of all of our kids that are in some form of out-of-home care, including our secure track youth, under a division called Special Services.
Great.
Paul?
Oh, Paul. This is tough not seeing you. Paul, please introduce yourself.
Good afternoon, everybody. And again, I wish I could be there. And thank you, Kim and Diana, Locke, Rachel, for allowing me to join you here today. And my name is Paul Vanetz. I'm a bureau chief with Los Angeles County Probation. And my bureau is, we call it probation child welfare. So anything that fits under that roof that's related to child welfare, kids that are in care, then they're under our bureau. And thank you for allowing me to join you today.
Thank you, Paul. Diana's going to start us off.
Yeah, so Locke. Okay, so Locke did tell you a little bit about complex care and some of the different placement opportunities and also services that kids can receive. And I'm going to, or Rachel, Paul, and I are going to talk today just about some funding opportunities to help support youth and children that are in your care. And so with AB 153, it was put into place and created opportunities for there to be funding for both child-specific and for capacity building, which I think is what Kim was looking for. Yes. And then it also established a children's crisis continuum pilot. And so with the child-specific funding, there is 18.1 million, and that will be happening on an ongoing basis. So annually, you will be replenished, and there's an allocated amount that you receive, and you can look at ACL 21-119 that gives information about that funding. It is meant to supplement different services or supports for the child, but not supplant. With the capacity building funding, this is to develop services and supports for children. There's 43.3 million. This is a one-time use funding, and you can look at ACL 21-143 that does give more information. One of the important things, and you'll hear me say this more than 3 or 4 or 5 times today, is that this is really about a system of care approach with the capacity building. So it's really important to work with the system of care integrated leadership team at your local level to really evaluate where there are gaps within your continuum and decide how you are going to build out those gaps. With the crisis continuum pilot, that is $61.3 million total. It's for a 5-year pilot, and it is our plan by mid-June. I'm looking at Marjana and John over there, who have really taken the lead in this process, that we plan on getting that RFA out. You guys can wave hi since everybody's looking over at you. So with the child-specific, some county examples, this is really, think about that this funding is used, it's based on an assessment that's been done. So it may be a behavioral health assessment done, it may have been something that a psychologist has completed on one of your probation youth, and it can come out of a CFT recommendation, the qualified individual recommendation, or even TA through the intensive services unit at CDSS. And it's identification of some exceptional needs needed to support an individual youth within foster care to be served in the least restrictive environment possible. And so some of the specific examples that we've had thus far that I wanted to share with you today is with this first one, assist a resource family home. So notice that I didn't say STRTP. This was actually a resource family home that requested one-on-one staffing for a youth so that he could remain within the home. With this, one of the first questions asked is, where's the mental health services? Well, the child was already receiving in-home behavioral support by a mental health specialist. They were receiving individual therapy by a clinician. They also received individual therapy within the educational milieu. So that's already 3 different mental health people. So to add one more person would not necessarily have been helpful. But what was identified is that by having a person that the family actually knew, that had previously worked within STRTP, come in to support that home environment, the child was able to remain in that resource family home with his foster siblings and the foster dad. And so this was a great use of the funding to keep the child at the lowest level possible. Another one is to support the needs of youth and family in enhanced intensive services foster home. Very similar to the first example, although the family identified that they needed additional support. Some of that support, Locke talked about this, was provided through TBS, so Therapeutic Behavioral Services, was brought in and provided to that child and family to identify what was some of the function of the behaviors that were happening so the correct interventions could be implemented. But then it was also needed some supervision, and so that supervision was paid for out of this child-specific funding. Supervision and support within an STRTP of 1. With this request, there was a couple different pots of funding that were used. One of them that was looked at was a flexible funding rate through AB 2944, also ACL 2221, where we were able to adjust the amount that was paid to that provider for the STRTP placement. Medi-Cal was also used to pay for services, but then the child-specific funding was used to pay for an additional one-to-one staff for that child that was needed. Payment of services not covered by Medi-Cal. So this is something else that we are seeing, that at times there's just not the capacity to be able to provide all the mental health services needed for a child. And so there has been a couple of occasions now where we have used this funding to pay for mental health services provided to a youth that couldn't be billed under specialty mental health services. And I am now going to pass it to Paul to talk about his experience of using the child-specific funding.
Hi, everybody, and thank you. So it's kind of part storytelling and part and mostly process. And everybody can hear me okay? Yeah, okay, so I just also want to acknowledge and thank my fellow panelists and everybody for being in this audience today. So I'm going to reference ACL 21-119, which really tells the story about the child-specific complex care needs. Most people can, I hope, can appreciate the situation where you're sitting there minding your own business when suddenly out of nowhere an urgent situation arises and you need to solve it now. So we had a situation brought to my attention. It's now going back into February. We have a child who's just turned 14, and I think on a Friday night, early Saturday morning, it was a weekend, a child, a female probation youth, who was identified as CSEC, who had been subject of a warrant because she ran away from a placement, was taken up into the mountains on the kind of, if you're familiar, San Gabriel Valley area, Azusa, Pomona area. I'm going to call her Tina for the argument of our presentation today, just for illustrative purposes only. And Tina, I'll get into all the issues in a moment, was taken, basically abducted by two or three gang members from that general region, taken up into the mountains, up to a fire trail, a fire road up in the hills, shot in the head, shot in the liver, and shot in the leg, and left for dead. Just had turned 14 like the day or two before, and got up out of the dirt, started walking down the road, flagged down a vehicle, and she was taken to the hospital. Ultimately, she lost her right eye and was in the hospital for a considerable, well, not too considerable, for about 3 weeks. And then we had to, she was recovering. She was at juvenile hall. We took her over to the hospital on a regular basis. When she was at juvenile hall, she eventually was able to be released from juvenile hall, but she had many follow-up appointments. We had a major security concern because the gang members, once they figured out she was still alive, figured they probably would want to go back and quote unquote finish the job. So we had to have we had to have escorts, secure escorts to take her to the juvenile hall, from juvenile hall to her medical appointments. And we're talking about a kid here who, that's why I asked the question about the DMID, because if we're going to talk about complex care needs, I hate saying this is the poster child, but when I called Diana to, kind of run this by her, we ran out of boxes to check or to tick off. I mean, we're talking about gunshot wound to the head, replacing her eye, gunshot wound to her liver, to her leg, a CSEC youth who was being trafficked, who was so heavily entrenched in gangs that her gang, which her mother was also a member of, felt like our child Tina had a lot of secrets of the gang and was going to start talking to law enforcement or whoever. And so she posed a threat to the gang. Several suicide attempts, self-injurious behavior, diagnosed major depression, had run away many times, and just let's say her family did not put the fun in family dysfunction. Okay, just very, very complicated across the board. Had been eventually, once she went through all of her medical treatment, the court wanted her and everybody wanted her out of juvenile hall. Where to put her? Well, a lot of us would have tried in the past many years to place her outside of the state. And if that was available, we would have, but since this, the state decertified out-of-state placements, we needed to find some place that was suitable to treat her on all of these different levels. And so ultimately, we thought that the best place for her to be would be in Vista Del Mar, and as Locke mentioned earlier, one of the two community treatment facilities in the state happens to be here in Los Angeles. And so we went through a number of conversations, but Vista Del Mar was very uncertain, concerned about having Tina in their program, considering all of the above. At which point I reached out to Diana to ask her preliminarily, is this the kind of child the complex care needs, child-specific complex care needs funds would be appropriate for? And the aspect of ACL 21-119, and I was asked this because we had a conversation last week or the week before, no, it was last week, a couple of weeks ago, was, are you supplanting your funding, or are there any other funds? And basically what we landed on was that the level of trauma that this child had experienced, and because of the I would call extraordinary acuity, required intensive mental health, intensive specialty mental health services. Knowing that she was an addict, knowing that she was gravitating towards a gang, knowing that she constantly ran away, we felt as though having somebody available to enhance the level of supervision, servicing care around the clock was appropriate. So Diana, I don't know if you can see this in person in the room, but I can actually see her on Microsoft Teams. Can you see her? Because from here, it looks like she has like this halo over her head, okay? At least there's an aura. It's my way of saying thanks to Diana for helping us navigate an extraordinarily complex case and trying to, with everything that's related to what we're calling complex care need. I wanted to put the word care into play here. this is a child who's brilliant. She's as smart as a whip. She wants a future. She has a future. It's that the issues that are weighing so heavily in her life, we really wanted to have an opportunity to get her all of the care that she needed. And we don't want to keep her at Vista Del Mar, which, as you know, is a secure facility. So not that after about a month or less, she actually figured out a way to escape and run away. And we found her and brought her back. And, you know, she is drawn somehow as a 14-year-old with, you know, whatever is going on with her, drawn back to the streets, very strongly drawn back. So this is my word of advice to everybody who's in the audience today. This is not a complicated process. The money is there. We have kids that this money can really help support. If you have a case that is kind of above and beyond, and I'm guessing, can I see by a show of hands? Because I can see the backs of some heads. By a show of hands, how many of you have a kid like that? Nobody? There's some hands up in there?
Yeah, there's hands up.
I can't hear you, Kim.
There's hands up.
Oops. Let's try again. Yes?
Yes.
There are some.
Yes, there's hands
Yeah,
up.
there you go. There's a bunch of hands up. You have that kid. I don't know if you have Diana's personal hotline number that flashes. I think it flashes green. It's like the bat phone. It flashes on her desk when one of these calls comes in, right? Look at her. She's blushing. She knows it's true. So the point is that I went to Diana. Diana helped me navigate this. So when we did it right the first time. Okay. I will very briefly, and then before I hand it off to Rachel, wrap up by saying, broadly speaking, our systems need to build capacity because there are a lot of these kids that are out there. And by building our infrastructure and taking advantage of the funding that complex care needs, funding allows us, it really allows all of us to, you know, I heard Locke speak. And that's why I was asking the question about the DMID, because these kids don't just have one or two issues. These kids have a whole bunch of stuff going on. And we have a whole lot of kids and families that have a lot going on. And I think that if we are creative and if we are working through our AB 2083 local system of care team, that we can really build up an infrastructure that makes a difference in the care of these kids. The complex care needs, the child specific is one aspect of it. And I'm really looking forward, and as you are, everybody in the audience, to hearing what Rachel has to offer here today as I pass it over to her. But we do have an experience at least in Los Angeles County. You have that in your county. Diana and the CDSS team are amazing resources, and I just want to encourage all of you to take advantage of that. And thank you very much for letting me speak here with you today.
Thank you, Paul. So Diana's going to talk about the next category.
Yeah, so I'm just going to talk briefly about the capacity building ACL 21-143 before I turn it over to Rachel. And here we are again. The first step of what you're doing in this process is to include your SOC, your system of care, interagency leadership team in the process of conducting a survey that is a part of that ACL. And it is there to identify the gaps within your continuum at the local level. So that is your very first step of what needs to happen. That next step is that with that ILT team, you are working together to create a plan to address those gaps. So this is money. It is sitting there. Probation has a pot, and then also child welfare has a pot. So you can decide if you're going to work together as a whole team, as Riverside did, or you can look at doing it separately if that is what is determined that you guys need as you're working with the ILT. Some of the plans that you may look at is enhanced ISFC homes, therapeutic foster care homes, high-fidelity wraparound programs, individualized STRTPs, intensive family finding models to support permanency. So those are all just different ideas that you can implement as part of the county capacity building. It is a process, and it does take some time. And really, I'm going to go ahead and turn it over to Rachel.
Thank you. So as I said, my name's Rachel Leitenberg, and I've had the pleasure of working for the probation department for 22 years. And where it started for me was as a probation officer facing that first youth that we didn't have a solution for. And that bothered me. And it bothered me for many years as I went throughout my career, and I was able to make it to a place where we could partner at such a perfect time, which is this time, with our behavioral health partners and our Department of Social Service partners, to really look across the table at each other and say, is it bothering you too? And I imagine that each of you might have a picture in your mind of who that youth is, and I know I do. So that's where we're going to start. Just about a year and a half ago, our department chose to realign and put all placement services under one management team. And that really helped us take a deep dive into how things were going. My first encounter was a youth who the screening packet was over 100 pages. I want to say it was close to 160 pages. And I sat down and read all 160 pages, and it bothered me. It bothered me that she was sitting in a secure track setting because there was no place for her, and that was not solving a problem. I was fortunate enough that this youth was a dual jurisdiction youth. And so I have a relationship with Bridget Hernandez. I need to give credit where credit is due. I call her Haley's Comet, and we just grab onto her tail, and she drags us along, make sure we're going in the right direction. So nonetheless, it felt very fortuitous that we came together about this time and had a conversation about how we could do a better job for this young lady. She had, I think in the social service world, they call it medically fragile. She had intellectual disabilities. She had multiple mental health diagnoses. And for us, the problem with that we wanted to solve was it seemed like she was missing that chip that made her realize she was headed towards a very dangerous situation. She was exploited whenever she didn't like what was going on. There was no conscious evaluation of things that we naturally would see as problematic or dangerous situations. So the example is that when she was done with whatever placement she was at, she had no problem running into traffic because she really didn't care if she got hit by a car. She also, as I mentioned, had some intellectual disabilities, and her evaluation was of normal life circumstances was probably of someone that was probably 10 or 11 years old. So she wanted candy, and so she would run away from the group home, and she would exchange a sexual act with a homeless person, so they would buy her a candy bar at a local liquor store. So you can see that this is a set of unique circumstances that usually in probation we have a lot of round pegs that fit into the round holes, but this was definitely a square peg and a round hole situation. And so that's where we started, was with a story. And I'll tell you that each of you has a picture of that client in your mind. Let that be your motivation to make sure that you go back, you read these ACLs, you talk to Diana. She has a bat phone, as Paul said. And that you reach across the aisle to, your behavioral health partners, to your DPSS partners, but don't let that be a barrier. If they are not in a position to partner with you, it's okay. As she said, there's a pot of money waiting for you, just like it was for us. So I want to mention that actually our partner for behavioral health is here today. I hope I'm not going to embarrass her, but she's sitting in the back in a beautiful coral sweater. Nonetheless, I remember the day that she sent Bridget and I an email saying, hey, did you know about this complex care funding opportunity? And it was great for us to know that there was not only help on the way for our girl that we have in mind, but also help to find more square holes for our square youth, right? Plenty of round holes. So we looked at that, explored that together. We internally, as a department, looked at where were our gaps. So I'm not sure how your placement units are structured, but we have a placement coordinator. And I just went and asked the question, how is it going? Are you having trouble finding places for these kids? Tell me what those kids are facing and why aren't we able to meet those needs? So it starts by being inquisitive, right? Partnering and being curious about how it's going. We were able to identify those gaps that we found, and partnering back with DPSS, we found some commonality with the gaps that we were experiencing. And after sitting and having lots of late night discussions, because I don't know if you know, but there's all this work that gets done between 8 and 5. And then the rest of us set up these calls that start at 5:30 and sometimes at 8 o'clock, so we can figure out how to fix some of those other issues. So the concerted effort in really identifying what those gaps were, and at the same time, we had just had an exposure to Seneca, an uplift, because of the expedited services that the state contracted for all the youth out of the decertification of out-of-state placements. And we got to see some of the wonderful things that they could do. And I actually was looking at my material from last year from the CPOC conference and being reminded of some of the things they presented even last year to us. So it was this kind of perfect partnership that started to come together. We met with them. Bridget really spearheaded that effort and experienced both the problem solving as well as the gap closing that comes with collaborating with other agencies. I think sometimes we think we should be self-sufficient in our problem solving, but there's often times that really reaching across in an unconventional way can bring in unconventional results that really can impact a life. One of the things I wanted to point out is in probation, we are not usually placing as many youth as DPSS is. And sometimes as departments, we make a decision about aligning resources and time to finding or to filling those gaps based on volume. And what I want to remind you is this is not a volume issue. This is one life at a time. When we looked at how many clients didn't necessarily fit that conventional placement model, it was sometimes a handful, it was sometimes maybe 2 handfuls. But what I want to tell you is that life matters. And don't let anyone tell you different. Don't let it stop you, because these are the youth that, too, if you want an argument for your executive team, these are two of the youth that are usually taking your resources away. Your staff are spending the most amount of time trying to find placement, right? These are the youth that usually tend to be unstable, so they're cycling through multiple placements. So when that comes up, now you're armed with, yes, it's worth the time, because we're going to create a system that supports youth that have unique needs, and we're going to reduce the trauma that we're putting them through with not getting them to the right place. Collaboration is key. as I mentioned. Really, if you're a department that already has maybe reached out to your social service partners and they are exploring a different route, I don't want that to be something that stops you. Collaboration doesn't always mean that it's going to take place with a county department. It means reaching out to those collateral agencies like I mentioned today about Seneca and Uplift. So we got together, to get back a little bit on track there, we got together and the ACL gives us guidance that we need to do a self-assessment. And I don't want you to be intimidated by the self-assessment or even, how much work do you need to get into before you do it. This is a self-assessment and it will ask you a number of questions about, do you have a placement that meets this specific need? And it's relatively simple to go through. And it will help you even probably explore some of the types of needs that you didn't even maybe put your finger on. So we sat down, we went through the self-assessment together, we submitted that, and then as I mentioned, we went back and had a discussion with Seneca, led by our partners in social services. And Seneca came back to us with an incredible plan to build this continuum of care to help us begin to close these gaps. We've highlighted a few there in the slides. The intensive stabilization services, so that's an example of an unconventional thing. Usually when we have a youth who's becoming unstable in a placement, you get a phone call, emergency CFTM, maybe it's a 14-day notice, and that is some of the strategy that has been used before when things aren't going well. But with intensive services stabilization, they actually are proposing to have someone report directly to that physical location where that client is to work with that group home, with, sorry, I shouldn't say group home, with that STRTP, to help stabilize the youth and to work hand in hand to, it also is meant for lower levels of care. So I said STRTP, but it's meant also for foster homes so that it can help support the family and resources there. We also have, tiered placement where it's intensive services, foster care provided as well as coupled with wraparound. Those services obviously can overcome a lot of those unique needs because of how highly individualized it can be. A team like that can be very agile in adjusting to whatever the emerging needs are with the client. And then we also have the crisis stabilization unit. This is something that is highlighted in a plan. And from each of those, the thing I want to point out is that none of us are doing that alone. And in that particular last example, we will be working hand in hand with our behavioral health department to help youth who maybe need a temporary reprieve because they're in a crisis. If that does not abate within that 23-hour period, then there's the next option for them to continue to get the need met. What they find statistically is that there's a flare, a crisis, and if you can address it and help the youth through it, that you can reach stabilization. It isn't something that, when a client is in that kind of state, that it's usually persistent for the majority of clients.
And Rachel, the crisis stabilization, that's a mental health service that you're talking about that you
Right.
partnered with behavioral health for?
Right.
Okay.
Right. So to go back and just sum it up, our goal today, my goal today, and I would say it's probably shared, we wanted this to feel approachable. We wanted you to feel like you had a path to solving this, and we want you to know that together, whether that's right, within your own agency or reaching across the aisle, consulting with CDSS, that there is a way and there is that funding that's available to accomplish that.
Great. Okay, so thank you. Let's give them a round of applause. Thank you so much. So one of the things you can see, one of the things that you can see is the merger from the presentation from Locke onto capacity building, because, there's the traditional, we do this and we jump through the hoops and we do all this stuff and it works, or it doesn't work so great, but it works. And then there's the, it doesn't work. It doesn't matter what you do, and you jump through all the hoops, you do all the complaining, and you go to your boss and it still doesn't work. And you get to capacity building and very specialized individual cases. So we want to see if you have questions. Again, Stephanie will collect any. And we do have a first one, and that is, this one is for Paul. Paul, child-specific funding. What was covered for Los Angeles? So what was the service or thing or what did you pay for with that individual money?
We paid for a range of things which we had initiated. I would not be telling you the truth if I said it was a completed process. But what we had done through child and family team meetings, through various other intensive efforts, was to establish at the very least a plan for this child. Now, what we wanted to focus on was intensive specialty mental health services. And in order to get into a CTF, and anybody here can correct me if I mistake this, but in order to get into a CTF, you really have to have a much higher, the need has to be much greater, okay? This child did not have much in the way of confinement time, so keeping her in juvenile hall, she had a couple of misdemeanors. I believe she was a dual, a 241.1 case where probation was the lead. And essentially what we were trying to accomplish, or the best way to use that money, was to start with what I will refer to, we wanted to focus on the most intensive need first. Okay, what was most intrinsic of that child where we needed to focus? And it wasn't that she was high risk. Her need was that we believed that her mental health condition, the trauma she had experienced, had to be stabilized. So if I take a page out of what I just heard both Rachel and Diana say, is that we needed crisis stabilization for this child. It was trauma-informed crisis stabilization. I would say that's what we were seeking, was just to get her stabilized. One of the things that we have in Los Angeles County, and again, this was a sex trafficked child, is that we also have advocates. Now, the advocate wasn't part of what we were paying for, but putting together that treatment team was not a mature process. Okay, it's going to take a lifetime for this child to heal, and we figure she's just 14. She'll be with us probably, in some form or fashion, at least until she's 18, and probably up through the time that she's 21 years old. Okay, so in order to answer your question, I think that we were seeking to find crisis stabilization for this child.
So
it was about crisis stabilization.
So you paid for a one-on-one above and beyond TBS?
Correct.
Okay. So
around the clock, we paid I think it was $600 a day. Is that about right? Is it $600 a day?
Diana says yes.
Yeah, $600 a day. I don't know if that's a bargain or if that's expensive.
Yeah.
But it seemed like the 18,000 was a drop in the bucket compared to our allocation.
So she got the mental health services that you're used to all hearing, TBS and individual and case management and all that, and that was insufficient. So you added another more 1-to-1. So now it's 2-to-1, 3-to-1 kind of thing?
Ours was right. We started with one person around the clock. Three different 8-hour shifts.
Right.
Yeah. We did not, if I was to do this again, I probably would want to double it because she likes to run.
Okay.
But, we would have to reconvene and pull together a CFT. She ran off again. She figured out a way to get away a second time. So when we find her, and we will, we have a protocol, get into the weeds.
Okay.
When we find her, we're going to have to, reconvene and come up with an enhancement on top of what we already thought
Yeah.
was a serious enhancement.
Okay. And then I think, Diana, you have a question?
No, I think
Oh.
you clarified it.
Oh, okay, all right. And then I just wanted to ask, so did my understanding, so this is kind of Diana and then Paul. So Diana, my understanding is you don't get the money the minute you fill out the form, right? So you do spend the money up front, and it's a reimbursement?
Correct. So what it would be is that you would submit an invoice to CDSS, and on the resource page, it gives an email for you. But you submit that invoice, and then you would receive that money after it's been invoiced.
Okay. And then Paul, so then my question for you is, how did you pay for it up front? What did your boss do or say, or how did that part work?
So in working, this is the kind of the crucial aspect, because folks are going to want to know that that Vista Del Mar understood that they were going to pay for it, provide the invoicing to us through our fiscal office, and then we would put together a packet and then forward that to CDSS.
Awesome. So does that make sense? I see so heads are nodding. Does anybody have any questions about that specific piece before we move on? Yes.
Could you be, once you submit the invoice, could you be denied reimbursement?
So the question, Paul, just so you know, was once you submit the invoice, could you be denied? And I think Diana's going to respond.
Yeah, so part of the process is that you are submitting your plan to CDSS, to rates, with the statement, because there is a one-pager, well, it's like 3 pagers by the time, it expands, because you're filling out the plan of how you're going to use the money for the child. It's being prior, and it's being approved, so it's approved, you know that you will get that money. And at this point in time, our approval is really, I would say, within 48 hours.
So that's really impressive. That's a quick clock. Okay. Yes, in the back?
Yeah, I just want to reinforce that we did that with the child, we got that funding, and I was shocked how quickly it was approved. Because I just figured it would take a while, but it was within 2 days.
Awesome.
And then we needed more, and that got approved too.
So you're from LA, and you're saying regarding the same?
No.
Oh, I'm sorry. Okay, thank you. So you had a similar experience in that reimbursement was quick. Did somebody say what department? Okay, all right.
We had a question.
Okay, yes.
I have a question, because it really depends on the staffing level of the placement. So what we're finding, a lot of placements don't have staff, even though there's funding for one-on-one.
Right.
I think that's becoming more challenging.
It is, that human resource issue is really killing us. Yeah, yeah. And we know that some STRTPs are not even filling their census that they're licensed for because they don't have the staff. Human resource is an issue. Yeah. Any other questions? Actually, for either topic, I just want to clarify, so you can combine your child welfare and probation money, but you don't have to. So you can do it either way. Okay, great. So partnering is good, but there's sometimes individual directions you need to go.
And I do want to let you guys know, you're welcome to have my cell phone number and call me with any questions. Happy to assist. I do also want to let you know that in noticing and recognizing that folks still may have questions or want additional assistance, we will be having a webinar that will be held on June 14th from 9 a.m. to 10:30 a.m. And I believe Stephanie has a flyer that she can make sure gets sent out. And we will be covering the capacity gap. We will also be talking about the behavioral health infrastructure grants that are available to pay for things like the crisis stabilization unit, or even if you're looking at building out a psychiatric health facility within your county. So those may be things that you want to tap into. And then also we will be discussing the child-specific funding.
So that requires registration?
It
Yeah.
does.
So
Yes.
you'll send that out, Stephanie?
I've already sent the flyer out.
Okay, awesome,
And contact as well as probation advisory.
awesome, okay.
And you
Ye-
said crisis stabilization unit? I'm sorry.
Yeah, so the behavioral health infrastructure grants, you can look at working with your behavioral health partners to build something like that out using that funding.
So just to clarify, again, crisis, it all sounds like semantics when you're not mental health. But in the Medi-Cal land of specialty mental health services, there is a difference between crisis intervention, which is what you're used to hearing people going in out from outpatient perspective, and either they're coming to the crisis unit, crisis staff may go out and do a home visit, somebody, you may just call them and they're trying to work with the use. That's still crisis intervention. Crisis stabilization is a 23-hour program where someone is there. And it's 23 hours because as soon as you're 24, then you're full-time residential, right? You're a hospital. So it's 23 hours. That doesn't mean there are times, I don't think, is DHCS here? There are times that kids have been released, or adults in the adult crisis stabilization, and then get readmitted in an hour or so. Shh. But the crisis stabilization unit, there just aren't a lot of them for kids. I mean, it's really, and sometimes that's just what, just give me 10 hours, you know? Just give me 10 hours with this kid. They don't need to be fully put in a puff or in a hospital. And so those are really awesome. And if you can partner with behavioral health, because we can say, oh, Medi-Cal covers it. Medi-Cal covers 50%, right? So 50% doesn't build a house. And so those are things that partnering, and because it's state money, it's matchable. So that's a big deal to now become whole, to create something you're missing in your county. Somebody else had a hand up. It's in, yes.
Checking for probation departments, are you able to use the child-specific funding from STRTP to like a parent's home, like once they're in a parent's home?
Child-specific funding?
So yes, and it would just depend really on what is it that you're implementing that isn't paid for by another pot of money, but absolutely, you would be able to get that child home.
Yeah, so it doesn't have to be in an STRTP
Yes.
or a CTF. It can
Yes.
be in foster home. It can be at home, right? So it could be a kid in that kind of situation. I thought I saw another hand go up.
And I don't know, this is the very last slide, right?
Yes.
So I do have a quick question.
Oh, no, I think there's the ACLs.
Okay, perfect. I have one additional question because with complex care funding, there's 3 categories. We've listed the 2, but how about the children's crisis continuum of care? I know that's probably still in the works, but can you give any updates or when a request for proposal or anything come out RFP?
So we are planning, this is a joint project with Department of Healthcare Services and CDSS. And so it is our goal as of last Friday, that it will be out, I would say mid-June. We need some additional agreements from the 2 departments, and then we will be releasing that RFA. I believe that our goal would be for, well, I don't even know how much I can say. So I'll just say that we're looking at mid-June for it to be released, and we're really excited about this opportunity. And hopefully we have some counties that partner with some providers and looking at implementing this pilot.
Awesome. We have just a couple minutes. Yes.
Can you use the child-specific funding for pre-RFA, like you have an emergency placement, to kind of establish, helping them get off the ground?
So that's a really good question. So the complex care funding is really designed to be used for those kids with high intense needs. So it wouldn't just be used across the board for all youth. Which is why, a child who's been in STRTP, in order to help support them get to a lower level of care, that funding could be used if it's one of your more complex youth. So what I would say is it would be an evaluation of what are the needs of this particular child, and is it keeping them from going into an STRTP or even a locked setting. So if that's the case, then we can evaluate that. Okay? Good question, though.
And then I just was going to ask Rachel, oh, I'm sorry, go ahead, Locke.
One of the things about this aspect about complex care funding is that you really try to sit down with your fiscal folks, probation fiscal, child welfare fiscal, et cetera. And then whatever amount that you start out with, start finding out or guesstimating as best you can where current funding might come from. So for example, even before this complex care thing, we had a youth go into College Hospital down in LA. They were quoting us $37,500 a month. In the end, it cost us about $500,000 because of how long the youth was there and whatnot. What we really pushed for was that, hey, you're a hospital. Doesn't that mean that you get some Medi-Cal reimbursement? So after really bird-dogging them, they finally said, yeah, it's about $150,000. So if we hadn't had asked that for that, they would never given us the $150,000 in terms of that. So same here with this. If you're going into there and they're saying to you, $10,000, $120,000 over that year period, ask them, what amount can you currently draw down from Medi-Cal? What amount can you draw down from the regional centers? And so on and so forth. Whatever is left, and including Title IV-E, whatever is left, then there's that possibility of complex care funding. And that's the amount you ask for. And that's a little bit more manageable for some than saying the original $120,000 is what you want. Because that would be the pushback is, well, what are you possibly supplanting, or what are you possibly not seeing?
I'm glad you said that, Locke, because that's a good opportunity for you to ask behavioral health to help you as you're looking at, it's a hospital, behavioral health will tell you, they know there's Medi-Cal billing involved if it's a foster youth, meaning child welfare or probation place. That's a foster youth. And so those kids have Medi-Cal, and we know those hospitals are billing Medi-Cal. So I have a question for you, Rachel. So you picked Seneca because you had already worked with them. So I think, and Uplift also? Yes, you'd already worked with them through the expedited transitioning program. So, but did you have a relationship with them before that? Like, did you have a contract with them or anything like that before?
Yes, we did. When we experienced the benefit of their expedited services, social services initiated a contract with them to continue and expand upon what they were doing. Family finding, more intense services for the youth, helping find alternate placements. So, and to tell part of Bridget's story is, in the midst of a crisis and a conversation with them, they had the insight to say, we are going to try to provide you some assistance in your crisis, but you're actually asking the wrong question. They saw something in the system that they could help fill that gap. And, we are so grateful for that insight that they provided. And then when the crisis was over, we came back to the table and said, tell us more about how you can help.
That's awesome. So I asked that because there's other partners than just your county colleagues that you tend to think of, the three county agencies, and it's real easy. And you may have some existing contract providers that you already have in your county that you're working with. Who had kids come from out of state back where you used the expedited transitioning planning? Oh, so not very many of you. So do you all know what that is? Okay, so you're nodding at least. Okay, so that expedited transition planning, I know CDSS helped pay for that and DHCS was involved too, but that's really not new. right? So those services could have been provided all along. You just have to think about them and put them together. And so that's where, as Locke said, doing that financial get-together. So I don't know about your counties, but I have worked in counties. Ooh, I said where I worked already. I've worked in counties where there's more out-of-the-box thinking from the fiscal folks, and I've worked in counties where the fiscal folks are really good at counting boxes, and only the boxes that are in line of sight. So one of the things you really want to do is make sure you're talking with your fiscal folks about the boxes that are outside of their direct line of sight, in their peripheral vision, and outside, because that doesn't mean those boxes don't exist. And they're the ones that are going to make it happen or not in the end. Any other last questions before we end?
So one last comment that I need to make is, remember, this work cannot be done by a single department or agency. It is a system approach that's going to make a difference. And please, 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 remember to include your local tribes in part of that conversation. Thank you.
Awesome. Thank you. Let's thank the panel, all of them, including Paul. Thank you. Thank you. Have a good break.